Thank you, Lisa, and welcome everybody. I appreciate your joining in on us for this Foot Innovate webinar. And the subject we're going to tackle tonight is that of talus fractures. Certainly one of the more difficult traumatic injuries to manage in regard to the foot and ankle. And I have taken the opportunity here to provide an overview of the diagnosis and management of certain types of talus fractures. And we thought we would go ahead and do this webinar on this subject and post it on our Foot Innovate website, because we do plan on having some more specific and complicated entities in the same area addressed in future webinars, such as the reconstruction and salvage of talus fractures going on to avascular necrosis and such. So without further ado, I wanted to present to you this overview of talus fractures based on our experience here in Charlotte. Now, just as a quick review, there are 5 articular surfaces of the talus with 7 facets, and those include the lateral malleolus articulation, the tibio-talar articulation, and then that along the medial malleolus, and then you also have the talar-navicular joint articulation, and then the anterior facet and the middle facet of the talus, as well as the posterior facet as we course more posteriorly on the talus itself. So again, it's a very interesting bone with no tendon or muscle attachments, but pretty much nearly the entire surface is covered by some type of cartilage surface. We have to remember, too, that the vascularity to this bone is very small. It's very precarious. And again, as a review, there are 3 blood supplies to the talus. One that arises off the perforating perineal artery that extends into the sinus tarsi and is called the artery to the sinus tarsi. The second is off the anterior tibial artery, or the dorsalis pedis artery, and that provides blood supply to the dorsum of the bone itself through a number of various small branches extending into the interosseous area. And then you have 2 blood supplies coming off of the posterior tibial artery. One is the deltoid branch to the talus, and the second is the artery to the tarsal canal. Most believe that the artery to the tarsal canal is probably the most vigorous and most important to the vascularity of the talus. Unfortunately, it's also the one that's most commonly compromised when one does sustain a significant fracture with displacement of either the talar neck or talar body. So again, that certainly is a review that there is a very precarious blood supply to this bone that is covered primarily by articular surfaces. What I'd like to do this evening is discuss fractures of the talar body, the talar neck, and then those of the lateral process. I am not going to discuss the shear injuries or the avulsion injuries of the talar head, nor are we going to discuss the osteochondral talar dome fractures in this particular webinar. Starting out with talar body fractures, these fractures comprise 15 to 20% of all talus fractures. The problem with these fractures is they basically violate and disrupt both the tibio-talar joint surface as well as the subtalar joint surface. So again, both sides of the talus are involved in this particular fracture, making it very difficult to obtain a good long-term result, one without the development of traumatic arthritis. We classify talar bodies based on the Boyd and Knight classification or some scheme thereof. And you'll see in this particular classification scheme you have type 1A, B, C, and D. The type 1 being the non-displaced one. The type 1B is that is minimally displaced. The type 1C is one that involves some degree of subtalar subluxation or dislocation. And then the type D is, of course, the most severe, and that's when your talar body is actually dislocated. It actually, if you think about this, it follows very closely that of the Hawkins classification that we know for the talar neck fractures. Another way to look at these talar body fractures is not by the surface arrangement, but actually by the line of the fracture itself. And you can have coronal line fractures, sagittal line fractures, horizontal fracture lines, or just severe crush talar body fractures. Interestingly, these talar body fractures rarely occur in one plane. Oftentimes there will be some degree of a biplanar configuration to your fracture, but again, one that will typically involve both the articular surfaces of the ankle joint and subtalar joint. Now, what's the management of talar body fractures? Well, in the very general sense, those that are truly non-displaced, the Boyd and Knight 1A classified fractures can be treated in a short leg cast, non-weight bearing for a period of 6 to 8 weeks, followed by progressive weight bearing in a boot. And that's a fairly well-accepted management philosophy for those non-displaced, truly non-displaced talar body fractures. Those that have any degree of displacement, whether it be a B, C, or D subclassification, will require a operative procedure, one that allows for anatomic reduction and interfixation. Oftentimes, these fractures require screws placed from the posterior aspect of the talus, and oftentimes one that requires a medial-malleolar osteotomy in order to access that particular area. Now, if you think about going posteriorly and having to do a malleolar osteotomy of this type to identify these fractures and anatomically reduce them and fix them from the posterior to the anterior direction, you really have to work around the posterior tibial tendon as well as the neurovascular bundle. So you have to be prepared to understand the anatomy along that posterior medial aspect of the ankle joint in particular. You have to basically do a tarsal tunnel release. You have to mobilize the posterior tibial tendon as well as the FDL and oftentimes the FHL tendons. There is a very small working space in this area, and again, you have to have good knowledge of the anatomy as well as good visualization of the important structures in that part of the ankle. And as my recommendation to go ahead and perform your medial-malleolar osteotomy if indeed necessary, but then also perform a tarsal tunnel release, identify your tibial nerve and retract it posteriorly so that you know that it is well protected throughout your procedure. These talar body fractures are interesting. You know, while we think of them as being severe injuries that oftentimes have significant amount of displacement, there are those that are minimally displaced and oftentimes hard to appreciate on your routine radiographs. So again, you need to have a high index of suspicion whenever you have somebody with an injured ankle that perhaps is not improving as they should with non-optimal modalities. On this particular example I've shown you here, you'll see that there's a fairly normal appearing lateral x-ray on the far left side. And then this person who did not improve symptomatically had an MRI performed, and you'll see on that MRI that there is a fracture line through the posterior third of the talar body, extending more on that medial aspect, and one that is consistent with a non-displaced or a 1A Boyd and Knight classified talar body fracture. You then see on an x-ray that was done 3 months after the initial, you can now see that there's a fracture line extending through the talus as visualized arising from the posterior facet of the subtalar joint and extending superiorly. Now, this is an example of the 1B fracture, one that was displaced but did not have subtalar involvement or subtalar subluxation or dislocation. And in this particular injury, a medial-malleolar osteotomy was performed, and then the fragment could be identified, reduced, and then held in place with 2 screws. So again, a good visualization there in the CT scans in both the AP and the transverse plane, showing that displaced fracture rising from the posterior medial aspect of the talar body, as oftentimes these fractures do. As I mentioned before, the problem with the talar body fractures is that they involve 2 joint surfaces of significant importance, the ankle and the subtalar joint. These fractures, because oftentimes they are biplanar fractures, oftentimes associated with significant amount of displacement and crushing, they are more predisposed to developing post-traumatic arthritis than any other complication, much more predisposed to developing the arthritis complications than they are avascular necrosis. Because of that, it's very important as the surgeon to not accept any degree of step-off or diastasis when managing these particular fractures. So you really want to spend your time well and obtain good visualization, work very hard and diligently to reduce the fracture anatomically, oftentimes with temporary K-wire fixation followed by rigid introfixation, usually in the form of 2 screws, and if the bone allows, these will be partially threaded screws of 4 millimeter size. I do recommend the use of headless screws whenever possible. You are oftentimes working under the medial malleolus or in that region of the joint, and I find that headless screws or recessed screws heads are very beneficial, particularly in that working area. So again, as shown here, this is an example of a body fracture in which there was some subluxation of the subtalar joints. This is a 1C classified fracture. You'll see that it was managed with a recessed head screw, one that was actually placed out into the bone and you can certainly use a variety of different headless screws to accomplish this. But again, recommended when you have a situation where you're trying to fix the fragment, and yet it's going to be one that could be in contact with the medium malleolus as it glides through the standard range of motion of the ankle joint itself. Now, with that said, let's move on to talar neck fractures. This is a fracture that was well described back in the early 1900s, the aviator's astragalus, and this is one that we oftentimes now see with motor vehicle accidents, the floorboard injuries. And it comprises 50% of all talar injuries, oftentimes in young patients with excellent bone quality. And this is the classic mechanism. This is the hyperdorsiflexin mechanism that we'll see with these injuries that create a tremendous amount of stress through the talar neck itself. And as mentioned, one that oftentimes occurs with the head-on collision of the highways. The classification for talar neck fractures was originally popularized by Hawkins in 1970. He described the type 1 as that's completely non-displaced. Type 2 is the fracture that's fairly clean, but with displacement and subtalar subluxation. And then the type 3 was one that occurred with a posterior talar body dislocation. Canale and Kelly in 1978 added the type 4 to this classification scheme, and that was one of either a type 2 or 3 Hawkins variety that also had subluxation or dislocation of the talar navicular joint. So this is the classification scheme by Hawkins. There's type 1 in the upper left that's completely non-displaced. The type 2 is one where you have displacement of the talar neck with subluxation of some degree of the subtalar joint. Now, interestingly, on a lateral x-ray, you might see what appears to be a slight dorsal displacement of that talar head and neck fragment, but actually what oftentimes is occurring in the type 2 is a rotational malalignment, a supination rotational malalignment of that fragment that gives it that displaced appearance, and you need to recognize that it is not only a displacement but a rotational malalignment that provides that appearance that we oftentimes see with the type 2 variety fractures. And then type 3 in the bottom right, the bottom left, you'll see there with the further displacement of the talar body, and then the type 4 with the subluxation or dislocation of the talar navicular joint. Now, in the type 1 fractures, these are the truly non-displaced talar neck fractures. In this scenario, which I wish was more common than what it is, it's not all that common to see these particular truly type 1 fractures. There is reported to be a 0 risk of development of osteonecrosis, at least under Hawkins' eye. If you look at Canale's work, they found a 13% osteonecrosis rate with these type 1 fractures, but with very mild circumstances. Most studies will show that the osteonecrosis rate with this particular fracture, if it truly is non-displaced, is very, very low. For this particular fracture, most authors would recommend closed and non-operative treatment. The only situation you may wish to consider internal fixation through percutaneous means would be that of a fairly elite athlete in which you hope to initiate a fairly quicker rehabilitation course with. One individual that you may wish to initiate range of motion of the ankle at a more rapid rate, and then may be amenable to percutaneous internal fixation. But otherwise, it's sort of the standard of care to treat these particular injuries in closed non-operative fashion. But still, if you do that, you need to be aware of the possibility for delayed displacement. And you don't let these people get out of your watch. Make sure they come back and have serial radiographs performed to make sure they don't develop any displacement, or particularly the malrotation we discussed with that distal fragment drifting in a supination malaligned position. With these fractures, weight bearing can usually be initiated somewhere between 6 and 12 weeks, and a number of people are now recommending obtaining CT scans to determine exactly when weight bearing can be initiated. Now, the type 2 fractures, these are the ones, again, that have displacement with subtalar subluxation. These have 50% osteonecrosis rate as defined by Canale. Hawkins noted a 41% osteonecrosis rate. If you look at the literature, the low range is somewhere around 20%, but again, it goes as high as 50 or 60%. But I think it's just important to understand that when you get to the type 2 variety as compared to type 1, that osteonecrosis rate is certainly present. Your patient needs to know about that at the very onset. Fortunately, non-unions of this fracture are fairly rare with appropriate operative intervention, and the non-union rate is usually reported somewhere less than 10%. Now, this is a standard Hawkins variety. You'll see that neck fracture there with the subluxation through the subtalar joint. What's interesting is a lot of these type 2 fractures, the subtalar joint subluxation may be more obvious than the displacement of the fracture. So even if you see a fracture that looks fairly well aligned, you have to always be wary of the possibility of some subluxation of the subtalar joint, and again, that being better defined on CT scan imaging, which is always recommended whenever you have a talar neck fracture. With these type 2s, the question is, can they be treated conservatively, non-operatively? Well, this was a claim that Canale and Kelly made back in 1978, where they felt that you could obtain an anatomic reduction in closed fashion in 60% of the cases by plantar flexing the foot and basically pushing it back into a posterior direction. Unfortunately, the reduction, even in their hands, could only be maintained if there was extreme plantar flexion. And I think that most of us now would consider the type 2 to be an indication for operative intervention where anatomic reduction is achieved, and then you provide rigid interfixation to avoid the sequela of malalignment, particularly varus malalignment or non-union to malunion. This varus malalignment issue is certainly probably the most significant complication we consider with this type 2 variety talar neck fractures. Now, why does this varus malalignment occur with these fractures? Well, for one, the bone density on the lateral side of the talus, on the lateral side of the talar neck, is greater than on the medial side. And also, there's supination forces that are involved in creating the fracture and also tend to bring that talar head and neck into that varus position. And so when you consider the fact that the bone is weaker on the medial side and you have these supination forces acting on the not only creating the fracture but how that it continues to displace over time, you then realize that this varus malalignment is always present, and particularly when you have a degree of medial comminution, which is always greater than lateral comminution. So with that said, again, we believe that it's very important to operatively manage these particular type 2 fractures. Stable fixation allows for early range of motion. However, you do need to remember that stable fixation does not allow for early weight burn. You still have to allow these fractures adequate time to heal, again, with their precarious blood supply and their risk of developing osteonecrosis. You also have to make certain that in the operating room, once your fixation is placed, that there is absolutely no varus along that medial aspect of the talus. It's important to get a modified or simulated Brodin's view to accomplish that. Brodin's view, the Canale views, those type of views that will bring the talus into a figure 8 configuration so you can actually see the outline of the medial cortex of the talar neck quite well to ensure that there is absolutely no varus malalignment. If your talar neck fracture should heal with varus malalignment, it changes the biomechanics of the hindfoot, specifically the locking and unlocking mechanism of the talar navicular joint. And these people will typically develop a cavovarus-like deformity with a rigid hindfoot, one that tends towards lateral overload and significant long-term problems. So again, very important in this fracture management that you make certain that there's no varus when you leave the operating room. How do we approach these talar neck fractures? Well, typically we do it through an anterior medial approach. This is the classic approach. This is the one that we'll typically use for our type 2 fractures where there is no significant amount of comminution or displacement. This is an approach that is done adjacent to the anterior tibialis tendon. You can dissect in just medial to the anterior tibialis tendon and obtain an excellent visualization of the talar neck fracture as seen there in the lower right. And then go ahead and you can place your temporary fixation either in the form of temporary K-wires or the guide wires for a cannulated screw system. It is important as you place the screws from this anterior medial approach to countersink them into the articular surface of the talar head. That requires that you're going to need to abduct the foot, subluxing the navicular out of the way of the anterior medial aspect of the talar head so that you can get good exposure to place those wires and subsequently to insert your screws. It's also important that as you do this approach that you don't excessively strip the periosteum around the talus. You're trying to preserve that blood supply as much as possible, particularly those perforating branches that are supplied by the anterotibial artery along the dorsum of the talus itself. Now, there is an anterolateral approach to these fractures. This is one that many believe is better for fixation because, as mentioned previously, you have more structured bone along the lateral aspect of the talar neck than you do the medial. The problem with the anterolateral approach is not only the risk of injury to the superficial perineal nerve, but also risk of injury to the anterotibial perforating vessels or even those vessels supplied by the perforating perineal artery to the sinus tarsi. But again, this is an approach that we oftentimes will recommend for higher grade injuries and those with medial comminution. It does allow for perhaps a better reduction and utilizes the contour of the sinus tarsi itself. So again, it's a good approach to be familiar with. With this anterolateral approach, you certainly can still utilize screw fixation, but what we've done here in Charlotte over the last few years is utilized plates along the lateral column of the talus. Again, we find that plates are very beneficial for the more comminuted fractures. You can utilize either 2 or 2.4 millimeter plates that are available in a number of different modular foot sets. There are now also available anatomic specific talar neck plates available on the market. So again, you have an opportunity to utilize different types of plates for this purpose, and you can see there in the photos in the lower aspect how the plate has been assembled and applied to the lateral aspect of the talus, utilizing the contour of the sinus tarsi itself. Now, there will be times when you need to consider a combined anterolateral and anteromedial approach for your talar neck exposure and fixation, and this is particularly true when you have significant comminution of the talar neck. I have a very low threshold to add a second incision. While my usual preference is to do an anteromedial approach, I will not hesitate to include an anterolateral or a lateral approach when I have a lot of comminution. I'm concerned about underlying varus malalignment. I want to utilize that strong cortical surface of the sinus tarsi for my fixation. And again, when you use those combined approaches, you can still use screw fixation if your bone's adequate. But in that a lot of these fractures are comminuted, you want to avoid compression. So if you do use screws, you're going to do them in a crossed fashion to avoid compression. You're also going to utilize fully threaded screws rather than those that are partially threaded, also to avoid compression of these comminuted fractures. It will be our case, though, to utilize plates in this situation. We'll oftentimes use a screw medially and then the plates along the lateral cortex. If you look at the studies comparing screws and plates for this purpose, they appear to be fairly equal in rigidity testing and other biomechanical testing methods. So again, certainly an opportunity there for these more difficult fractures. So this is just an example. This is an anterolateral, anteromedial approach to the talar neck fracture. Again, you'll see the countersinking of one screw that's placed from the anteromedial aspect, specifically through the talar head's articular surface, where it needs to be countersunk, and then you'll see that other screw that is brought in from the anterolateral side, utilizing the more firm cortical surface of the sinus tarsi for good fixation. This is just another example. This is somebody who underwent this procedure, and you'll see the cross screws again brought in as the illustrations show from both the anteromedial and anterolateral aspect. And again, this is a canale view in the operating room, ensuring that we have no varus malalignment within that internal fixation construct, and again, utilizing 2 cross screws that are fully threaded to avoid compression through the comminuted bone. We certainly don't want to lose any length of that talus as we bring the distal and the proximal fragment together. This is just another example. Here's our incisions along the anteromedial and anterolateral aspect, and then again our provisional fixation in this situation utilizing a headless screw construct with recessed position in the anteromedial aspect of the talar head itself. And the position on the lateral x-ray, again showing those the screws in appropriate position there. Lastly, this is a more difficult talar neck fracture with a near body dislocation, but still a type 2 situation. It's just a more violent injury. And in this situation, you'll see here that we actually used a screw placed in the anteromedial aspect and then a plate along the anterolateral aspect. You can see there in the bottom middle radiograph that that plate contours the sinus tarsi quite nicely and provides excellent fixation along that more rigid bone laterally as compared to the weaker bone medially. So again, this combination of a medial screw and the lateral plate essentially provides almost a tension band type of effect on the fracture itself, and we find this to be a good combination for these more difficult fractures, again, utilizing the combined anterolateral and anteromedial approaches. Now, there is a posterolateral approach that can be utilized for talar neck fractures, particularly those that are the more simple type 2 or even some of the type 1 varieties that need internal fixation. Posterolateral approach is one that's done lateral to the Achilles. It utilizes the lateral tubercle of the posterior process of the talus as the entry site. And typically, the patient that undergoes this posterolateral fixation is in a lateral or a prone position. Now, the question is, what role should the posterior screw fixation play as we manage these patients with talar neck fractures? Well, obviously, it's been identified that there's a theoretical biomechanical advantage. In a study by Swanson in 1992 and subsequently by the Medical College of Virginia, they found that posteriorly placed screws appear to have a better biomechanical advantage, more rigidity than those placed in the anterior aspect of the talus. But what we've found anecdotally is there's probably not a significant clinical advantage to the posterior placed screws as compared to those that are placed in the anterior aspect. One of the problems with posterior screw placement is that a lot of these talar neck fractures are somewhat distal. And then the concern is, can your partially threaded screws placed in the posterior aspect actually cross the fracture site and provide the compression that's desired? So that's one thing to consider when you entertain the possibility of placing a screw from the posterior aspect. The other thing we've realized over the years that the window for screw placement along that posterolateral aspect of the talus is very small. Number one, you have to be aware of the FHL tendon from a soft tissue standpoint, but the other is that if you utilize a screw with a large head, particularly the 6.5 millimeter screws, you can create a posterior impingement phenomena. So people will say, well, let's use a 4.5 millimeter screw. Well, there's been studies done that have shown that basically there's just not a lot of room back there for two screw heads without creating some impingement or some soft tissue concerns. And in prior studies, there's actually been noted that possibly there's room for one screw head of 4.5 millimeter size or greater and one K-wire. So again, there's just not a lot of room out in that area of the hindfoot to utilize for the screw placement. So again, you can see here that that is the window there along the posterior aspect of the talus. And logistically, you'll find that these screws are not easy to place. You know, people are trying to do this from a percutaneous standpoint, again, placing the screws from posterior anterior using that small window. It's very possible your entry site can be too high, and that can lead to poor fixation of your talar neck as well as to impingement. And again, you'll see in that bottom right that the screw heads, there's two placed there, they're just too prominent, and that creates a posterior impingement problem. And I don't know if you've ever had the opportunity to try to remove these screws when they do create impingement, but it's not the easiest procedure to undergo. So again, I feel that possibly the theoretical advantages of placing these screws posteriorly is not warranted, and just the logistics of trying to get a reduction in a prone or lateral position, which is better for placing these screws, is very difficult. So again, my feeling is supine is the best position to get a good reduction of the fracture, make sure the fracture is well aligned, to get adequate x-rays, and because of that, I'll usually tend towards utilizing screws from the anteromedial anterolateral aspect or fixation along the lateral aspect of the talus, and I have abandoned the use of these posteriorly placed screws for these talar fractures. Now, what about the type 3 fractures? Well, these are indeed the worst. These are the talar body dislocated fractures. About 50% of these are open, and this is an orthopedic emergency, not necessarily for the avascular necrosis that may follow these, but because of the skin concerns. That large posterior talar body fragment resides in the posterior aspect of the ankle joint, and it can create a significant amount of skin necrosis over a very short period of time, as well as significant compression on the tibial nerve, resulting in significant and permanent paresthesias to the distal foot. There is a significant osteonecrosis rate, as you suspect, with these fractures, about a 69 to 100% reported rate with a 12% non-union rate. Now, obviously, the problem with these fractures is all three blood supplies are disrupted, therefore making for very poor long-term results. We talked about the four arteries from three blood supplies that provide viability to the talus, and unfortunately, with this severe dislocation of the posterior talus, these are disrupted in one manner or another. So we do want to fix these relatively quickly. We put these on an urgent basis. We oftentimes will approach these through the medial aspect. We'll oftentimes consider a medial malleolar osteotomy. And you can also utilize calcaneal pin traction and flex the knee to provide the space that that posterior talus needs to be reduced back underneath the distal tibia. So again, little maneuvers that can be very helpful in bringing these fractures back into proper position so that then you can manage them as you would a standard talar neck fracture. So this is, again, an example of a Hawkins 3 fracture with significant posterior displacement of the talar body, and one that was managed with medial malleolar osteotomy and then screws placed from the anteromedial aspect of the talar head, reducing the fracture adequately. This is the same fracture, and fortunately 2 years later that particular individual did not develop osteonecrosis or non-union. This is one of the more unusual good results that we occasionally will see with management of these particular fractures. So again, just understand the very significant nature of these fractures with their high risk of osteonecrosis and their urgency for fixation. So, in just concluding on talar neck fractures, what are the controversies out there? Well, I've highlighted some of them. One is, are type 2 fractures orthopedic emergencies? What fixation is best to use? How long is a weight bearing protected? And what do we do with the open extruded talar bodies? These are controversies that are out there. And tackling them one by one. First, the type 2 fracture is an orthopedic emergency. Well, there's been very little data in the literature over the last several years. Articles in 1985 were basically conflicting one another. One said that there was a 33% osteonecrosis rate with 2/3 of the patients getting early surgery. And then there was another one by Globe stating that there was a 0% osteonecrosis rate with 2/3 of the patients getting early surgery. Therefore, they were promoting that they be treated as an emergent reduction basis. But these are very small series, very variable operative techniques. And I think you really have to look to more recent literature to understand that there's probably not an orthopedic emergency in regard to the management of these type 2 fractures. This particular article in JBJS back in 2004 showed that the timing of fixing type 2 talar neck fractures was not so much of a factor as it was the degree of comminution, whether they were open injuries. This was another article in 2005 by Patel who did a survey of orthopedic trauma experts from around the country, and most orthopedic traumatologists feel that it's okay to manage the talar neck fracture that's displaced after 8 hours from time of injury, and then 46% even felt that after 24 hours was acceptable. So I think that there are injuries that you now can feel comfortable with waiting to the light of day and until you have a more rested operative team before you do tackle them. What about fixation? Well, again, we talked about plates versus screws. I believe screws are adequate for the majority of these injuries, but again, remember that plates are available and recommended when you do have comminution, particularly along the medial aspect, and can be beneficial in avoiding the varus malalignment. If you are going to use screws, I have gone to utilizing titanium screws just because of the possibility of developing osteonecrosis with these fractures. I believe that the presence of titanium screws may be beneficial if you want to follow the fracture along with MRIs. I do not have much of a preference in regard to cantilever or solid screws, although I do find that cantilever screws are beneficial in allowing for initial fixation with the guide wire, making certain that your alignment is good before placing the screw itself. Like we mentioned before, we'll use a partially threaded screw for a one plane fracture where we're trying to get compression. We'll use a fully threaded screw, usually in crossed fashion, if we're dealing with comminution. As far as the size is concerned, I mentioned this before as well, I do prefer the 4mm size, particularly if I'm using 2 screws. In regard to protective weight bearing after these injuries and after surgery, really there's no good studies on this. In a simple sense, you just want to protect your weight bearing until the fracture is healed, and we will use serial CT scans to help us determine when that fracture is healed. There is no evidence out there that prolonged non-weight bearing protects against developing osteonecrosis or collapse. So, again, I believe that following your fracture along by CT scan is probably the most beneficial in knowing when to weight bear the individual. And then lastly, what do we do with these really horrific open extruded talar body injuries? Examples as shown here, and these are indeed very difficult ones. There are several small case reports of rehabilitation, and I credit Dr. Saltzman when he was at the University of Iowa for these particular case series here. But he did some work with Larry Marsh and reported in 1995 their series of 18 individuals who had extruded talar body injuries from open fractures, and they had 7 of 18 develop deep infections, 8 of 18 developed fair or poor results. There's no clear answer on what to do with these particular injuries, but I do think it's reasonable to try to salvage the extruded talar body to cleanse it, sterilize it, and then re-implant it and then stabilize it with temporary K-wire fixation. Complications of these talar neck fractures, again, as we mentioned, avascular necrosis, basically reported from 0 risk with a type 1 Hawkins to up to 100% with Hawkins type 3. And you see the other complications include that of infection, non-union, malunion. And then, of course, there's the complication of arthritis. And again, this is quite significant when you discuss the Hawkins 3 variety, where the risk of arthritis is 70% at the ankle joint level and 30% at the subtalar joint level. So again, a significant problem that we face with these difficult talar neck fractures, and one that, again, your patient needs to understand as you initiate the treatment and rehabilitation course following their particular injury. You will occasionally come across a talar neck malunion and non-union, and these are indeed very difficult. They're oftentimes associated with traumatic arthritis of the subtalar joint. In these situations, they need to be managed with bulk allografts, of which you typically utilize an iliac crest or femoral head allograft, depending upon the size of the defect and non-union. And then that is typically followed by either a subtalar or triple arthrodesis, one that will help to stabilize the joints around the bulk allograft itself. So again, occasionally these talar neck fractures don't do well and have to be salvaged in one form or another. I think when you do talk about salvage of these talar neck injuries, that you are trying to maintain either a functional ankle or subtalar joint, if not both. Obviously, our preference is to certainly preserve an ankle joint over a subtalar joint, but both are important. And as you try to preserve those joints, that is often dictated by the extent of avascular necrosis or collapse. If at all possible, we try to salvage utilizing isolated hindfoot fusions, whether it be at the subtalar, tenovicar, or tibio-talar joint level. There are times that we've had to resort to doing a hindfoot fusion followed by a total ankle arthroplasty, and that is feasible as long as you don't have a significant amount of osteonecrosis of the entire talar body. People have reported on talectomy as a way to salvage these difficult fractures when they involve both joints above and below the talar body. And, of course, a lot of these fractures have to, unfortunately, be managed with extended arthrodeses, of which most popular technique is utilizing retrograde intramedullary nail with lock fixation. If you do resort to doing this type of salvage for these unfortunate complications, you want to try to leave the talar navicular joint open if at all possible to at least provide some opportunity for a dorsiflexion and plantar flexion to assist with ambulatory efforts afterwards. Now, just briefly, I want to go on to the lateral talar process fracture of the talus. This is a very interesting fracture, one we're seeing more and more of, particularly as the snowboarding sport is heightened in popularity. It's a fracture that occurs not only in snowboarders but also in windsurfers, and it's now become the second most common talar body fracture. It can involve the posterior talocalcaneal, joint, but it can also involve the talofibular joint. It can cause significant disability if it's unrecognized. And again, the mechanism for these is an acute dorsiflexion with inversion. There are type 1, 2, and 3 lateral talar process fractures. The type 1 is a very small avulsion fracture. The type 2 is a larger single fragment, and then type 3 is the comminuted fracture configuration involving usually the entire lateral talar process. These fractures are oftentimes very difficult to appreciate on plain radiographs. And I think if you ever suspect that you may have a patient with a lateral talar process fracture, you need to follow them up with a CT scan. CT scan imaging is certainly the way to identify this fracture, diagnosis, and determine what type it is. And as you'll see here in this particular CT scan, this is best categorized as a type 2 variety with one major large fragment that's displaced off of the talar body in that lateral aspect. Now, this is an example of a young athlete. This is somebody who was sliding into a base and had a injury that would promote this type of lateral talar process fracture. You can see there on the radiograph that there is obviously some abnormality in the lateral talar process. Unfortunately, this was initially not recognized, and the young man continued to have a significant amount of pain as he tried to rehab and play through this injury. An MRI was subsequently performed, and that is now shown there in the middle of the slide, and you'll see that there's obvious edema in that portion of the talar body, that lateral aspect, and if you look closely, you'll see that there's even some disruption of the articular surface, but unfortunately this was read out as a bone contusion with edema and still not recognized as a true lateral talar process fracture. It wasn't until CT scans were performed 2 months thereafter that this young man was found to have a significant lateral talar process fracture. So again, it behooves you to go ahead and to follow these radiographs up with a CT scan if you have any concern about a lateral talar process fracture at all. How do we treat these? Well, the treatment regimen and algorithm is certainly anecdotal at this point in time. Our preference is to manage the type 1s where there's a small avulsion or the non-displaced type 2s with cast immobilization. If we have a displaced fracture and is less than 1 centimeter in size, we'll typically consider excising the fracture fragment on an acute basis. However, you can excise these with success even if done late for a symptomatic non-union. If we encounter one of these lateral talar process fractures that's displaced over 1 centimeter in distance and there is no comminution, then we will consider fixing them. If you do fix these fractures, though, you have to make certain that that articular surface of the subtalar joint is beautifully reduced, because you certainly don't want to create a malreduction that would quickly lead to the development of arthritis of the subtalar joint. In that situation, it would be much better to excise the fragment than to fix it. So again, if you are going to fix these, you have to make certain that that subtalar articular surface is well reduced and maintained. Obviously, the complication for the management of lateral talar process fractures is the subtalar arthrosis. Again, if you have any malreduction, that's going to increase your risk of developing that symptomatic arthritis. This is an example of a lateral talar process fracture that was large in a single piece. This is the type 2 variety that in this situation was treated with a single screw and an addition of a K-wire to assist with preventing any malrotation of that single fragment. But again, you'll see that the subtalar joint is very nicely reduced and there's no evidence of a step-off. This is an example of somebody who's had a talar process fracture that is managed through excision. This is a sinus tarsi approach that nicely visualizes the sinus tarsi, the lateral aspect of the subtalar joint, and this lateral talar process. And you can see here that several fragments were removed from that region of the foot. And again, these do very well. And actually, we have found that you can remove quite a bit of the lateral talar process without developing any significant instability of the subtalar joint itself. This is the illustration after the fragments have been removed. This is a case, unfortunately, of one that was missed and the patient developed a significant late subtalar arthritis. You'll see there the changes in the lateral process itself. It's gone on to heal, but with a malunion and the development of degeneration of the subtalar joint. There's lateral x-ray, and then this was treated with a isolated subtalar arthrodesis utilizing single screw fixation. And again, this is the typical way to manage these lateral talus process fractures that do develop symptomatic subtalar arthritis, whether by a malreduced ORIF or a missed fracture that has developed the arthritic problems. So again, we've tackled tonight the lateral talar process fracture, the talar body fracture, and the talar neck fractures, and hopefully this will provide a good overview of the diagnosis and management of these injuries. In summary, I think it's just important to understand that the goal of any of these talus fractures is to attain an anatomic realignment with rigid fixation, and further understanding that that rigid fixation may provide you the opportunity to begin range of motion at an earlier date, but not necessarily early weight bearing. Your weight bearing, again, is restricted until the CT scan notes adequate healing. I think, again, that it's very important to acknowledge the potential complications of osteonecrosis and arthritis and inform the patient from the start of those potential complications, and then watch for them very carefully as you proceed through the recovery course. If you do unfortunately develop one of the complications, you need to be creative with your salvage opportunities. You'd want to try to save and preserve as many joints as possible. And again, I will tend to try hard to salvage the tibial-talar joint, even if it means having to fuse the subtalar joint. Obviously, I believe the biomechanics is more important at that ankle joint level than the subtalar joint. But again, you want to try to preserve as much joint motion as you can when dealing with these difficult salvage situations. I thank you for your attention. I now open the floor to any questions that there may be.